Welcome to part 3 of the Hypertension Pharmacotherapy lecture. So let's talk about some general concepts for pharmacotherapy for hypertension first before we get into the details. So once daily regimens are preferred for medication adherence. We're going to see that these patients can be on a couple medications sometimes, and if we can optimize their therapy by somehow, making sure everything is taken once in the morning or once in the evening, or if we can combine, two medications into one combined tablet form so they only have to take one pill. These are all ways that we can increase medication adherence. And there's 4 preferred drug classes that are recommended for initial treatment for hypertension. They are the ACE inhibitors, the angiotensin receptor blockers, the dihydropyridine calcium channel blockers, and the thiazide diuretics. So most patients will be started on one of these 4 medications. And which one they start on is going to depend on the patient, right, and their unique factors. One thing to note here is that sometimes these medications can be combined, but there's one combination that we will never see, which is an ACE and an ARB. So again, most patients will require 2 or more drugs, especially, when we're at stage 1 where non-pharmacological therapy alone didn't work, and now they're on the first agent and it's still not working, or patients that are already at stage 2 hypertension. So we do see a lot of patients with hypertension on multiple medications, but when starting them off, one is usually appropriate. And the first medication should always be maxed out before adding a second. So, if we start a patient on the initial dose for, lisinopril, for example, which is an ACE inhibitor, we want to make sure we're at the max dose for lisinopril before we add on, say, for example, a thiazide diuretic. Now let's talk about some general counseling points for hypertension medications. For one, we want to try to take these medications at the same time every day. And this is because, 1, it'll make it easier for the patient to remember to take the medication at that time. And 2, we know that blood pressure values do fluctuate throughout the day. So if we try to take them at, whatever time is recommended, the patient take it to have the maximal benefit on their blood pressure, and also while decreasing adverse effects, depending on the time of day they take it, then we're going to go ahead and do that. For example, water pills or diuretics can increase urination. So we don't want patients to take that at night, because then they might have nocturia, which is waking up in the middle of the night to use the bathroom. No one wants to have to do that, right? So trying to take the medication at the same time every day is something we recommend for all blood pressure medications. And we want to tell the patient to keep taking the medication even if they feel well, because again, most patients with high blood pressure are asymptomatic. We want to remind them that lowering their blood pressure is going to help reduce the risk of complications such as heart disease, kidney disease, and stroke. And we want to tell the patient to monitor their blood pressure at home if they're able to, and keep track of those values so that they can share them with their provider. So monitoring their blood pressure at home serves 2 purposes. 1, it will have those logs available for them to share with their provider. And it will also kind of let the patient be involved in their own healthcare. They might not be asymptomatic. They might be asymptomatic, but if they can see that their blood pressure is elevated when they're checking it at home, and then see the difference that their medication makes for them in lowering their blood pressure, it might encourage them to keep taking that medication as prescribed. And then lastly, medications that lower your blood pressure might increase your risk for orthostatic hypotension. So again, this just means that, sometimes going from sitting to standing, they might feel a little dizzy, a little lightheaded. So important to let them know that that might happen and how to deal with that, right? So getting up slowly, especially for older patients who are at risk for falling from this lightheadedness or dizziness when they get up. So for every therapeutic class, we're going to go over what medications are in that class, including brand and generic when applicable. I'll have a table with the dosing, but this is really for your reference. If there's any important notes to make about doses, I will definitely highlight them. But it's good to get familiar with these doses and just kind of be comfortable with them. I'm not going to ask for specific dosing, but they're there for your information. Then we'll talk about contraindications, warnings, side effects, monitoring, all that good stuff. And then lastly, important counseling points for each specific class, or occasionally for a specific medication within that class. So let's start with the thiazide diuretics. So the thiazide diuretics are listed to the right there, and note that they mostly end in thiazide or zone, except for indapamide, which had to be a little different, and end in amide. Thiazide diuretics, as we stated previously, are a pretty great first-line agent for most patients, especially if they don't have any other comorbidities or don't have any allergies to sulfa drugs. Out of the thiazide diuretics, chlorthalidone is considered to be the preferred diuretic for higher blood pressures, but hydrochlorothiazide is a good effective option too. So in general, you will see chlorthalidone and hydrochlorothiazide prescribed most frequently, but these other options are available too, especially in situations where we might need an IV thiazide diuretic for a period of time. We can use chlorothiazide. So in general, all of these are effective options for lowering blood pressure, and how they work is by inhibiting sodium and water reabsorption in the distal convoluted tubule. So this is going to cause increased excretion of sodium, chloride, water, and potassium. And if we have increased excretion of fluids and electrolytes, we're going to see a decrease in volume and ultimately a decrease in blood pressure. So some additional notes, as promised, on thiazide diuretics. If a patient has an allergy to sulfonamide-derived drugs, this is a contraindication to thiazide diuretics because there's some potential cross-reactivity there where they could have an allergic reaction to it. And in general, patients will usually know if they have a sulfa allergy, so it's just important to ask and make sure that it's documented in their chart. Warnings for thiazide diuretics include severe renal disease. This can precipitate azotemia, even progressive liver disease. If there's fluid and electrolyte changes, extreme changes can precipitate hepatic coma, and both of these kind of stem from the fact that, thiazide diuretics are working through, changing our fluid and electrolyte homeostasis, so it can, precipitate these events. Thiazide diuretics also, on that note of, renal function, aren't effective if a patient's creatinine clearance is less than 30. So very important number to remember there as far as thiazide diuretics and when we would have to stop using them for patients that have renal dysfunction. Metolazone will still work, but, at this point when their renal function is that poor, might want to consider just switching to a different class altogether, especially when there are other classes used for hypertension that are also renal protective and can therefore serve a dual purpose, and address high blood pressure while also helping out with the kidneys a little bit. So some potential side effects are, changes in electrolytes like we just discussed. We'll see decreased potassium, magnesium, and sodium. We can also see some increased calcium, uric acid, LDL, triglycerides, blood glucose. So this isn't to say that every single patient that's on this medication is going to experience these changes, but it's just something that we would monitor, right? We'd monitor blood pressure, obviously, to make sure it's decreasing, but we'd also monitor electrolytes, uric acid, blood glucose, especially in patients with diabetes, CMP, and just see what kind of changes are happening and make sure that nothing is, going really out of range that we need to do anything about. Some other side effects include photosensitivity. There's even a small risk because of that increased photosensitivity, increasing non-melanoma skin cancer, impotence, dizziness, and rash. Moving on to counseling, obviously if a patient has a sulfa allergy, like I mentioned, they should definitely let their provider know. But again, it doesn't hurt to ask, especially if a patient is starting this medication for the first time. Since the thiazide diuretics don't have, sulfa somewhere in the name, it might slip their mind. So definitely ask, and if it's not already in their chart, document it so that no one tries to start a thiazide diuretic in the future. We want to recommend patients take this medication in the morning. It is a diuretic after all, and it's going to increase urination. So if the patient takes it at night, they might experience nighttime awakenings to use the bathroom, and we don't want that. It's going to affect their medication adherence. We can tell them some of the potential side effects, but of course, with the caveat that not every patient is going to experience these side effects, just something that may happen that we want them to be aware of. And then lastly, more rare drug interaction here. We don't have a lot of patients on lithium, but if they are, diuretics can sometimes increase lithium clearance, and we would want to avoid this combination because we want to make sure lithium is within the levels that their provider wants them to be on to, target whatever disease state they're using the lithium for. Moving on to the calcium channel blockers, or the CCBs, as I'll now refer to them as. We have two subcategories for CCBs. We have the non-DHP, or the non-dihydropyridine, and the DHP, or the dihydropyridine. The non-DHP CCBs have less vasodilation and cause more cardiac depression by exerting their effects on the SA and AV nodes, which are super important for the normal cardiac cycle and contraction and all that electrical stimuli that's in our heart. The DHP calcium channel blockers work primarily on vascular smooth muscle cells. So there are a lot of DHP calcium channel blockers. I only have 3 of them listed here, and then on the next slide we'll kind of look at all of them. So it's much easier for you to remember that there's only 2 non-DHP CCBs, and that's diltiazem and verapamil. So we can use both of these for hypertension, but we wouldn't use non-DHP calcium channel blockers for patients who have arrhythmias or certain other heart problems because of their mechanism, they might exacerbate those conditions. So we can use both of them, and you should be familiar with which ones are DHP and which ones are non-DHP. But again, much easier to remember these, much shorter list than the DHPs. So we'll talk about the DHP CCBs first because there's more of them. So they're listed to the right there, and you can see that they all end in dipine. So amlodipine, nicardipine, nifedipine. So pretty easy for those to stand out. And then the ones at the bottom there that I've grayed out are not used as frequently in practice. So as stated, they inhibit calcium from entering vascular smooth muscle. So it's in their name, they are blocking calcium, and this ultimately causes peripheral and arterial vasodilation. So these are a pretty good option for a lot of patients too, of course, unless they have, diabetes or CKD, when there are better first-line options for hypertension available. And again, as far as efficacy, when comparing these agents, they all work pretty well to lower blood pressure. It's really going to come down to, what's available for the patient, what the insurance will cover, what the provider's preferences are when prescribing different calcium channel blockers. So the non-DHP calcium channel blockers are listed to the right there. You'll notice that there are a lot of different formulations for diltiazem and verapamil when it comes to, ER tablets, ER capsules. And we want to make sure we're checking the Orange Book and choosing generic products that are AB rated to the brand product when substituting for these medications. Not all generics are therapeutically equivalent to the brand name products. And then also noting that, 12-hour ER formulations are different than 24-hour HR formulations. If a patient is taking, the 12-hour formulation, they're taking it every 12 hours, twice a day. If for some reason in the future the doctor wants to switch them over to a 24-hour capsule, to help with adherence or whatever the case may be, we want to make sure we're counseling them. Okay, this is the same exact medication, right? Same drug, diltiazem. You're going to see the same name on the bottle, but now we're going to take it once a day. So calcium channel blockers, the non-DHP ones, have negative inotropic. Inotropic means decreased force of ventricular contraction, and chronotropic, chrono, like time, chronologic, and that means decreased heart rate. So again, if a patient has, certain problems with their heart, arrhythmias, 2nd or 3rd degree AV block, atrial flutter, or AFib, we don't want to use non-DHP calcium channel blockers. Alright, and there's a lot of information on this slide. We're going to try to just go over the important points here. So, out of all the contraindications, I would say, the most important one is that hypotension or that potential cardiogenic shock, 2nd or 3rd degree AV block. or having sick sinus syndrome, acute MI, pulmonary congestion, atrial flutter, or AFib. And then some warnings here. In some cases, if we have calcium channel blocker toxicity, we can actually see hypotension or severe hepatic impairment. Heart attacks and or death can even occur. The impairments, hepatic, and the hypotension, good news is usually reversible once the calcium channel blocker is stopped. So the side effects include peripheral edema, headache, flushing, palpitations. Sometimes we see reflex tachycardia, which is increased heart rate, fatigue, which is worse with nifedipine, the immediate release formulation, and sometimes we can see nausea and gingival hyperplasia. So gingival hyperplasia is a random, rare side effect of calcium channel blockers, but we can see it sometimes. Hopefully, if a patient is being seen annually by their dentist, dentists can catch that and ask them the important questions, try to get to the root cause of it. One of those questions being, have you started any medications lately? What medications are you on? And hopefully can catch that it's a calcium channel blocker causing that. Monitoring for calcium channel blockers, of course, includes blood pressure for efficacy, heart rate, because it can have effects on heart rate depending on, the non-DHP or DHP. We want to check the EKGs out too, because again, may exacerbate AFib or atrial flutter. And then LFT is also for the non-DHP, because again, some hepatic impairment is possible there. Now, some good things about the calcium channel blockers is that amlodipine is actually considered safe if a calcium channel blocker must be used to lower blood pressure in patients that have heart failure with reduced ejection fraction. So again, in general, patients with certain heart conditions, we don't want to use the calcium channel blockers, but amlodipine is considered safe if we have to, as in they have contraindications to other first-line therapies, or they've tried other first-line therapies and they weren't effective. So if we have to use a calcium channel blocker, amlodipine is the safest one. And then nifedipine ER is actually the calcium channel blocker that we use for patients that have hypertension and are pregnant. So remember, we talked about ACEs and ARBs, no-go. Nifedipine ER is a good option for pregnant patients. And then lastly, big important drug interaction with calcium channel blockers. Some statins, simvastatin, lovastatin, and atorvastatin are metabolized by an enzyme called CYP3A4. I don't think you guys have gone too deep into pharmacogenomics yet, but 3A4 is an enzyme the liver makes that helps metabolize and clear medications. And calcium channel blockers actually inhibit 3A4 or make it not work as well. And so if a patient is on a calcium channel blocker and a statin, we might see accumulation of that statin, and therefore we might see increased risk for toxicity. So this might lead us to choose a different medication for this patient. If they're already on that statin and they have great cholesterol control with it, we don't want to change that. We might use a different hypertension medication. Or if we have to use a calcium channel blocker, we might just make adjustments to their statin dose. Counseling for the calcium channel blockers includes telling the patient to watch out for signs of peripheral edema. Are they noticing any fluid retention in their legs, ankles, feet? That's where it happens most commonly, but sometimes we can also see it in the arms and hands. We also want to tell them to look out for reflex tachycardia. Sometimes when our blood pressure decreases as part of the body's attempt to maintain blood pressure, the heart might start beating faster, right? So the short-term regulators of blood pressure might feel like they're sensing an acute change in blood pressure and try to correct it. So if we use longer release formulations of calcium channel blockers, this is less of an issue. And then we already talked about the gingival hyperplasia. Lastly, Adalat CC or nifedipine ER patients might see a ghost tablet in their stool. So this is just the outer shell of the capsule that's still there. This is totally normal. They got the full dose of their medication. Nothing to see here. Really, hopefully patients don't try to show you their stool pics, but if they do, you just tell them it's normal, you got your medication, that's just the outer shell left over. Alright, so we are moving on to the heavy hitters here. So we're talking about the ACE inhibitors and the ARBs. So these are the last two medications that we have as part of our, 4 initial therapy options for hypertension. So ACE inhibitors, most of these end in pril, as you can see on the table here. Well, pretty much all of them end in pril. And I would say there's lots of ACE inhibitors around, and we use a lot of them. I kind of, grade out the ones I don't see as frequently, but, I have seen all of them used. And I see lisinopril used the most, but, anytime one of these goes on back order, which happened a lot during the pandemic, with supply and demand and operations, supply chains issues and all that. So we'll see patients switch around, but yeah, these are the most common ones that I see used. And they work by blocking the conversion of angiotensin 1 to angiotensin 2, which is going to decrease vasoconstriction and decrease aldosterone secretion. So we have this two-pronged approach to lowering blood pressure. So these drugs are really, really effective. But, if they're so effective, why don't we just start everyone on an ACE? Why do we even bother with calcium channel blockers or thiazide diuretics? Well, if a patient's blood pressure is just slightly above goal, we don't need to use something that's going to lower their blood pressure a lot and put them at risk for adverse effects. And we want to reserve these, heavy-hitting drugs for when it might be more beneficial to the patient. So, for example, some patients with comorbidities like CKD, diabetes, these patients will be good candidates for starting an ACE inhibitor first instead of, say, a calcium channel blocker or a thiazide. Patients with stage 2 hypertension, again, their blood pressure is already higher than patients with stage 1 hypertension. So it would be appropriate to use kind of a more effective drug for lowering blood pressure for these patients. And then, even if they have stage 1 and they have maxed out a calcium channel blocker, a thiazide diuretic, for these patients, it might be appropriate to add on an ACE inhibitor or an ARB. So let's start talking more about ACE inhibitors. So a big important boxed warning for ACE inhibitors is that they are contraindicated in pregnancy. So if a patient has hypertension and they're controlled on an ACE inhibitor and then find out that they're pregnant, they should discontinue the ACE inhibitor immediately. A lot of times in my lectures we talk about, the proper protocols for recommending changes to medication therapy. We like to call the provider or tell the patient to follow up with their provider before we make any changes. This is one situation where we don't need to wait. If they're pregnant and they're on an ACE inhibitor or an ARB, they need to stop it immediately. And then they can follow up with their provider and get started on a medication that is safe in pregnancy. So warnings for this, the two big ones are bolded in red there, the angioedema and hyperkalemia. So angioedema is swelling of the deeper layers of the skin, usually caused by buildup of fluid. In ACE inhibitors, we see it more often in the lips, tongue, or face, and Black patients are at a higher risk of experiencing angioedema. And this is another reason why, for Black patients, we recommend thiazide diuretics or calcium channel blockers as first line. But anyone with a history of angioedema should not try an ACE inhibitor just because of this potential risk, right? And also, there is a drug, Entresto, used for heart failure that has an ARB component to it. So if a patient was on that, but now for some reason they're switching to an ACE, we just want to make sure that they wait 36 hours before starting an ACE, because of that overlap kind of duplication of therapy going on there. Alright, so side effects. In general, these medications are pretty well tolerated. They can cause a consistent dry cough, which obviously is very annoying for patients. I'm sure you guys have heard about it already, so I'm not going to harp on it. But this dry cough is, not anything to be concerned about, just a potential side effect of the medication, and it'll stop once the drug is stopped. And hyperkalemia, which we talked about, it's a big warning, and that's why we monitor potassium levels. And we talked about, ACE inhibitors being a big offender for hyperkalemia in the electrolytes imbalances last block. ACE inhibitors can also increase serum creatinine. They can cause hypotension, dizziness, and sometimes headache. So this is why we also monitor renal function, because of that potential risk of increasing serum creatinine values. So counseling for ACE inhibitors, this medication, like we said, may cause a dry cough. So with COVID and flu season and just common colds making a comeback now that we've all stopped wearing masks, it's important to let patients know that they're not sick, no need to be concerned or, go and get a COVID test. This is just a weird side effect that happens from time to time, and the cough will stop once the medication is stopped. So tell patients if they are trying to conceive or are pregnant that this can cause serious birth defects, and they should let their provider know immediately if they are pregnant and they're on this medication so that they can get switched to something more appropriate. This medication can increase potassium levels, as we mentioned, so not only are we monitoring potassium, we're also going to let the patients know, try to avoid any other medications or supplements that can also increase potassium levels. And like some diuretics, we also see that potential for lithium toxicity. Alright then, so here we have the ARBs, so the angiotensin receptor blockers. The angiotensin receptor blockers basically do the same exact thing as ACE inhibitors, they just work in a different part of the pathway. So these are also a good first-line option for patients that have certain comorbidities or patients with stage 2 hypertension. The ARBs end in sartan, and like other classes that we've gone over thus far, the preference on which ARB to use depends on a lot of different factors, what's available, patient preference, the provider preference, all of that stuff. But I've seen almost all of these used in practice. So also very effective. Not much difference is really shown between the ACEs and ARBs. We tend to go with ACEs more. There's a lot more of them available. But the ARBs, do the same exact thing. And they're also great candidates for patients who may have risk for angioedema because they have a lower risk for that. And also they're good candidates for patients who tried ACE inhibitors but couldn't tolerate it because of that cough that was annoying. So all of this is pretty much the same as ACE inhibitors. One thing I will point out here is olmesartan has a potential risk of causing severe chronic diarrhea with substantial weight loss, and this can happen, months to years after the drug initiation. So it's something just to be on the lookout for and let patients know if they have sudden onset chronic diarrhea with, no other potential cause. And it can even happen months to years after starting the drug, so just something to be aware of. And another big difference, like I mentioned, they don't have as much risk for that cough. It's very, very, very low risk. And same thing with the angioedema. It's still possible, but significantly less likely to happen with the ARBs. Alright, so counseling points for the ARBs. Again, very, very similar to the ACE inhibitors. Two drugs that I will add a little something extra on is that for azlosartan, you got to keep it in the original container, and same thing for telmisartan. So telmisartan comes in a blister pack, which is annoying if you've ever had to use a blister pack yourself and having to puncture each tablet when you're ready to take it. But that's how the manufacturer packages that medication to work best and retain its potency. So it's interesting because I had a patient who was on telmisartan and he absolutely hated the blister packages so much. And so one time he asked the tech if she could just pop them all out for him and put them in a vial like all his other medications. And the tech was so nice that she agreed to do it, but then said, but let me just check with my pharmacist first and make sure I can do that. So she came back to me and I was like, no, we should not do that. So I went up there and talked to the patient, and explained to him a little bit about, the properties of medications and why some have to be stored certain ways to work best for you. And he was totally all right with it, right? Never hurts to ask. But yeah, so those two medications, those two ARBs have certain storage conditions that have to be met. And that's pretty much it for the main first line therapy options for hypertension. So this is going to be the end of this lecture. And then we will move on to kind of the second, third line alternative options for hypertension, add-on therapy, and all that in part 4? Yeah, so go ahead and wrap up here, fill out any parts of the study guide that corresponded to this lecture, and then you can move on to the next section.